A very warm good evening to everybody. Am I audible?
Yes, ma'am.
So a very warm good evening to everybody and welcome to the CARDIOCRINE 2024. This is a collaborative initiative of WINCARS Association with the Endocrine Society of India, and I thank all of the participants of this meeting. Without any further delay, we will first like to invite Dr. Jyotsna Maduri. She is our founder and senior advisor of WINCARS Association. Professor Maduri was actually the head of department of Nizam's Institute. And in fact, to her lies the beauty of starting this organization and bringing it here. Today, women in cardiology have a position because of her, and she has numerous accolades. She's been in numerous conferences. She's editor of the Indian Journal of Cardiovascular Disease in Women, has given opportunities to a very large number of women, and written multiple books, papers, and published many of them. And without any further delay, we would like to invite Professor Jyotsna Maduri to please say a few words.
Thank you, Sarita, and thank you to the whole of the Association of Endocrine Society of India. And I'm so happy that like women in cardiology and the related sciences, there is a women wing in the Endocrine Society also. And I welcome all of you to have a good academic discussion today. And I wanted this to be continued further, not only in the virtual meetings, but also in the physical meetings and the representation, your cases and your studies in our textbooks and in collaboration internationally. Welcome all. Thank you.
Thank you so much, Jyotsna ma'am. And we will now move to our first session. Our first session, I would like to invite the chairpersons for the session, Dr. Sujata Viparla. Dr. Sujata Viparla is Director of Indus Hospitals, and she's also presently the Vice President in Women in Cardiology and Related Sciences. And she's a very avid interventionist, has performed more than 25,000 procedures, and she's also development editor of the Indian Journal of Cardiovascular Disease in Women. So she's going to be one of our chairpersons for our first session. We also have Dr. Emmy Greville with us. And Dr. Emmy Greville is the Principal Consultant Endocrinology, Max Hospital, Mohali. She's received the A.V. Gandhi Award for the best research work in field of endocrinology in 2010 at Mumbai. She's also received multiple other awards, the MMS Ahuja Award, the A.V. Seth Award, numerous publications in national, international journals, and published chapters in a lot of books. Welcome, Dr. Emmy Greville. We also have on our esteemed panel, Dr. Swati Ramteke. So she's a consultant endocrinology at WIMSRC Bangalore, and she's also the endocrinology affiliations director, and she also has numerous publications to her name. And along with Dr. Swati, we welcome Dr. Asha Mahilmaran also onto the panel. Dr. Asha Mahilmaran is a senior interventional cardiologist at Apollo Main Hospitals, Chennai, with more than 25 years of experience in interventional cardiology. Again, she has published numerous articles, abstracts in national and national journals, and been a reviewer for the IJCVD, the International Journal of Diabetes, and many other such journals. She's presented a very large number of presentations in international conferences such as the EuroPCR, the CCT Kobe, and many others. So welcome to this esteemed panel. And our speaker for the evening is Dr. Gagan Priya. Dr. Gagan Priya is going to be speaking about endocrine disruptor chemicals and the cardiovascular system. She's executive committee member of the Endocrine Society of India, numerous publications, 71 journal publications, 30 book chapters, full books, and she's founder of the FLAME organization, the Forum of Ladies in Medicine. So we'll welcome Dr. Gagan Priya to please deliver her lecture.
Thank you, Dr. Sarita. And with the permission of the esteemed chairs, I'd like to, this is actually congratulate, first of all, WINCARS for inviting us to collaborate with them. It's really a very, very fruitful endeavor, which I hope will go a long way ahead. And I've been with WINCARS on various projects for the last couple of years. So I really know they are, in the zone for us. So today my talk would be endocrine disruptor chemicals and the cardiovascular system. And this is a very, very interesting topic for me as well, because when we talk about the current age, we've read history and gone from the Stone Age to the Bronze or Iron Age, and now is the age of plastics. In a way, this has been called the Anthropocene, that is the era where the earth is being affected by man in a big, big way. And yes, the plastics and the chemical industry did bring with it a lot of benefits for us, but we'll try and answer the question, how much of it is boon and how much of it is bane? Now, if we go way back to, it was around 1950s when plastic ushered in a whole new era. So what are they? Basically complex heterogeneous synthetic chemicals. They have a carbon-based polymer backbone. So that's the basic structure there. And then to get some kind of stability or specific properties, there are additives added to the carbon-based polymer backbone. We don't have a problem with this polymer, but it is the additives that bring in the problems. The additives could be flame retardants. They could be those that added color, like dyes, etc., or heat resistance, flexibility, like the PVC plastic needs flexibility, or there is a need for water repellents. So it is these additives that we will by and large talk about, and we'll understand that these additives go way beyond plastics into even household goods like our soaps and creams and lotions, etc. And in fact, they are present in almost every aspect of contemporary life, and research has shown that almost 40% of what we are using is disposable. In fact, this cover picture of the Life magazine in 1955 kind of advertised plastics as throwaway living disposable items, cut down household chores. So they were meant to make life easier. And yes, in the short run, they have made life easier. But let's look at where the science moved forward into understanding that these chemicals are not without problems. Earlier it was thought these are man-made chemicals. They don't exist in nature. They probably do not have any effect on the living beings. But this was changed by one of the pioneering women in environmental science, Rachel Carson, who had been working on environmental science for a long, long time. And she published this book, Silent Spring, which brought about a revolution. She talked about reproductive failure in birds with the pesticide DDT. And interestingly, in her book, there were 4 chapters which focused on what impact DDT was having on humans, but to a large extent, she was discredited in the initial period by the chemical industry. And it was later when John F. Kennedy had a scientific advisory committee which validated all of her work that there was a nationwide ban on DDT. Mind you, DDT still continues to be used in the malaria control program in India. This led to creation of the EPA Environmental Protection Agency in USA. And of course, later on, the United Nations Environmental Protection Program began. More insights came from certain pharmaceutical disasters like the thalidomide disaster, which we all remember. There were birth defect pictures in our textbooks with that, or diethylstilbestrol exposure of the pregnant women causing rare cancers in the progeny, in the female progeny. Then there were so many accidents and occupational toxic chemical spills that were reported. Fence line communities were affected. And there are accidents with dioxin reported with Italy, in Japan. And there was one incident where rice bran oil was contaminated with furans in Taiwan, and it caused disaster. In India, very recently, there was a very bad incident where 23 children died because of contamination of oil, cooking oil, with the monocrotophos OP pesticide. So what was understood that the assumption that only rarely could synthetic chemicals disrupt homeostasis, this got challenged with all of this background. And in fact, this toxic chemicals, skipel, and all of these, occupational exposures, they have been the theme of a lot of movies, including Hollywood and more close to us, the Bhopal gas tragedy. Many of these were nominees for Oscars, etc. But till now, the research rested on the idea of acute toxicity. What if there is a chemical spill happening? Of children being exposed in utero and there being birth defects, of malignancies and reproductive dysfunction, and also neurobehavioral dysfunction. So this is where the science took us so far. So it was the first society, I'm happy to announce that it was the Endocrine Society, US, 2009, that took its first stance against endocrine disruptor chemicals and issued the first scientific position statement by a medical body, defined EDCs as an exogenous or non-natural chemical or a mixture of chemicals that could interfere with any aspect of hormone action. How they could work? They could mimic certain hormone at their receptors or block those hormones. So estrogen and progesterone receptor, androgen receptor, even thyroid receptor has been found to be a target for some of the flame retardants, the retinoic X receptor in the liver, or even PPARs. They could affect hormone synthesis, transport, or metabolism, or their downstream signaling. They could cause inflammation, oxidative stress, ER stress. They could cause mitochondrial dysfunction or gut dysbiosis. Another important point of concern with all of these chemicals, especially chemicals like DDT, was they bioaccumulate in adipose tissue and they also biomagnify up the food chain. So from the lower animals to the upper animals, and since humans would be considered at the top of the food chain, biomagnification was also happening. And very often than not, there was a long latency period between when the exposure happened and when the disease manifested. Sometimes even decades later, diseases were manifesting. So how they disturb the endocrine milieu, a myriad of intracellular or cellular targets, cell surface targets have been identified now, and they're all common, the estrogen receptor, the androgen receptor, the PPAR. These are some of the molecules that have been identified and how they act either on the cell surface receptor or nuclear hormone receptor or the downstream signaling pathways. What are the EDCs? They could be pesticides, fungicides, insecticides we are using. They could be used, the additives I talked about that are used in polycarbonate plastics or in epoxy resins. They could be solvents or lubricants like the polychlorinated biphenyls, flame retardants or what are called as PBDEs, plasticiders, which are added like phthalates to give certain specific properties to our plastic material, or parabens that are used in personal care products. The list is actually endless. In fact, there are over 1,800 chemicals which the US FDA now flags as potentially EDCs. So they are not rogue, molecules or rare contaminants where an accident happens and we get exposed. They are global and ubiquitous. They come from food, they come from toys and other plastics, they come from food contact materials, especially plastic packaging. Even the Tetra Pak inside may have certain EDCs. Electronics, furniture, textiles, all of these could be ways we could get exposed to EDCs. And the exposure could be via ingesting them, inhalation, or dermal contact. And a sorry state is that there is also transplacental and breast milk transfer. In fact, biomonitoring studies, especially using samples from the NANS data in 2013 and 14, it was found that almost all humans in the US who were tested, they had detectable levels of EDCs either in blood, urine, or certain tissues. Of course, the tissue studies have only come from autopsies, but in blood or urine, 95% of the population had detectable levels of endocrine disruptor chemicals. So they are ubiquitous. And these are some of the chemicals that come in common, household items. We have food contact materials. There's bisphenol, there's phthalates. In children products, lead was a very big concern in the past, though yes, lead in plastics is getting banned very rapidly, but phthalates still come, cadmium might still come. Pesticide exposure still happens in India, and DDT is used in the malaria control program still. And we have antibacterials like triclosan, which are present in our day-to-day. A lot of personal care products like lotions, etc., might contain triclosan. Another division of these EDCs is whether they are persistent or non-persistent. Persistent are those that don't get degraded easily, and they can persist for decades. In fact, some have calculated that some of these molecules may remain in the environment for over 2,500 years, and they may get transferred from one to the other place, either through the ocean water and the polar regions where there has hardly any habitation, where DDT has been found contaminating some of the samples. Then there are non-persistent EDCs like phenols or phthalates or parabens, which are present in our day-to-day household items. So we do get exposed. And while they don't biomagnify, they can accumulate in the adipose tissue for an individual, and still their levels might be high. So while the initial research was focusing on what happens, it may cause adverse birth outcomes like preterm birth, low birth weight. Neurobehavioral disorders were strongly linked to the flame retardants, the autism spectrum disorder, ADHD, etc. Male reproductive dysfunction causing birth defects at the time of birth. Male children could have cryptorchidism, hypospadias. Reduced fertility and sperm quality in men was an issue. Females, endometriosis, fibroids, PCOS, early puberty, reduced fertility, all of these have found their links, and a lot of malignancies have found their links. But more recently, cardiometabolic concerns have been added to the list of concerns of EDCs, and this concern is equally important. One of the ways how the cardiometabolic risk might increase is based on what we call as the developmental origin of health and the disease determinants. And epigenetic dysregulation can happen because of EDCs. And studies indeed have shown that several EDCs, especially the flame retardant PBD or the PFAS, which is present in plastics, they have been associated with low birth weight, as well as phthalates, which have been associated with preterm birth in a lot of birth cohorts and registries. So they could induce the thrifty phenotype. At the same time, prenatal exposure has been linked to a higher body weight later down the line in these children. So adiposity indices have been low birth weight at birth, and then later on adiposity in childhood. Again, we have associations for PFAS, bisphenol A, and phthalate, and they're coming from all over the globe. So it's not just the US that's providing the data. We have data from Italy, we have data from Taiwan, and so many other countries, which are showing the same, that prenatal exposure to an EDC, especially PFAS or bisphenol or phthalate, could cause childhood obesity down the line. The same thing about exposure in children. We know children have, hand-to-mouth feeding behaviors. They'll pick up anything from the ground, or they will not wash their hands after playing with a plastic toy. They might put a plastic toy in their mouth. So again, exposure to EDCs has been linked to childhood adiposity and even childhood dyslipidemia. And for lead, there was very concerning signals that lead exposure in children was linked to higher blood pressures in children, a higher BP trajectory, as well as a greater prevalence of hypertension in children as well as adolescents. Similarly, endocrine disruptor chemicals like PFAS and phthalates especially have been linked to a greater risk of gestational diabetes. And in fact, for PFAS, which is present in plastics, 6 cohort studies across the globe showed compelling concerns that it increases the risk of impaired glucose tolerance in GDM during pregnancy. And again, a strong association is there for the PFAS with the risk of polycystic ovary syndrome also. A meta-analysis of 25 studies reported that so many of these, the bipheноls, the flame retardants, the PFAS and phthalates, all of this had signals linking them to GDM. Another important term that we often use is obesogens, because endocrine disruptor chemicals also act as obesity-promoting chemicals. And again, you can see a wealth of data coming in right from the Nurses' Health Study to the WHI initiative, or the Pounds Lost trial, wherein it was found that PFAS reduced resting metabolic rate. And you see the evidence for, again, the same bisphenol A, PFAS, phthalate. So these three are emerging as signals of obesogens across the globe. And how do we get them? Plastic food containers, heating food in microwaves, plastic water bottles, they can be common sources. Similarly, the risk of type 2 diabetes was linked with the same three molecules. A higher urinary BPA bisphenol A level was linked to insulin resistance and hyperinsulinemia. And in fact, it had, of all the three agents, the strongest association with diabetes risk. And it was found in one of the Clarity projects from US that metabolic adverse effects were seen even at those levels which earlier scientific bodies had said were safe limits. So there is no safe limit for bisphenol A exposure. And a lot of times now, if you look at children water bottles, they are being advertised as BPA free. So BPA is being replaced by another bisphenol, BPS, and I'll talk about it shortly. Phthalates also have, again, a strong relationship with risk of diabetes. PFAS is another plastic molecule wherein both insulin resistance is being increased, as well as it seems that in animal studies it reduced beta cell function, and it has been linked to higher rates of type 2 diabetes. So we can see the evidence is very strong for BPA. There is some data for phthalates and other molecules as well. Right. So there's plausible evidence that they are obesogens as well as metabolic disruptor chemicals. So the term that's been now said is that EDCs may also be MDCs, metabolic disruptor chemicals, and they act through a lot of pathways. They may impair insulin secretion, increase fat synthesis, they may impair insulin action, they may affect PPAR, oxidative stress, and they may also alter the gut microbiota. Coming to the link with cardiovascular disease directly, lead has a strong association with increased CVD and CV mortality, in addition to a risk with the association with hypertension. Similarly, cadmium, though cadmium exposure is mostly in smokers or fence line communities of heavy industries where cadmium is being used, it has been linked strongly to hypertension, myocardial infarction, CVD, and mortality. And cadmium very particularly has been found in carotid plaques and has been associated with plaque vulnerability. Similar signals, yes, I'm winding in 1 minute. Yes. Okay. Yeah. So bisphenol A has again shown similar relations. And a Hispanic community study has shown that over 7,000 Hispanics, when they were studied, the pesticide and solvent exposure was associated with a 2-fold increased risk of CVD and 6-fold risk of cerebrovascular disease. So what are the mechanisms? Diabetogenicity, obesity promotion, inflammation, oxidative stress, hypertension, and of course, epigenetic programming. So it's not just about the planet. We are not just trying to save the turtles and the birds and the fishes that we talk about. More than 6 gigatons of plastic waste has already accumulated in 50s. Yes, the planet is important, but we also are. In fact, the Mindero-Monaco Commission, this was a very large project report published in 2022 that calculated what is the healthcare cost that comes out of the EDC exposure, and the numbers are phenomenally high. And it's also a whack-a-mole problem. We ban on one EDC, another one pops up. So it's like the cat is, going around whacking a mole. And the BPA free, which is being advertised, doesn't mean EDC free. BPA may be replaced by BPS, which is again an endocrine disruptor. So what are the solutions? Reduce plastic, reuse plastic, recycle, maybe go organic, avoid plastic food containers, avoid heating in plastic containers, replace non-stick. That's another important source, in fact, of PFAS, the non-stick cookware. Once that starts eroding away, you end up eating the PFAS. And read labels for known EDCs. So EDCs are ubiquitous. They may contribute to the risk of rising prevalence of NCDs. We do need more research into safer chemicals, and we need to implement measures to avoid exposure. So we started with Rachel Carson, one heroic female, and I'll end with Greta Thunberg saying, I want you to act as if your house is on fire, because it directly is. Thank you so much.
Thank you, Dr. Gaganpriya, for that wonderful lecture. And it's actually a very eye-opener lecture, because it actually opens us to the fact that many of the things that today we use without even thinking about it is harmful not only for us, but also for the rest of our families, for our children, And special concern is also the pregnant mothers, because without knowing it, they are injuring the child in the womb. And EDCs are something that we need to deal with. You're very right when you said that humanity cannot afford the cost which people have to pay because of these EDCs. And a very important point which you also emphasize, that those cute little labels which they put on and they say, oh, this is BPA free, it's just been replaced by another agent which is equally toxic, because BPA free doesn't mean that it's BPS free or it's BPF free. And we need to look at all of those things, simple things in changing our daily lifestyle, like avoiding plastic usage, avoiding microwaving plastic, and avoiding the use of all of these things and going organic would help in a large way. But all of us have to get up together and fight this problem of EDCs, because it's interfering with health in all the ways. It's interfering with the children being born healthy. It's interfering with children growing healthy. It's interfering with the risk of non-communicable diseases, which is going up day by day. And we're not even aware. It's such an important thing is happening without us being aware. And I'm sure a lot of people are not aware about this, which is what makes your lecture so wonderful, because everybody listening to you is going to go back home today and take some measures to protect themselves and their families. Now we'll go to the expert panel for the comments and for the questions to Dr. Gaganpriya. We'll start with Dr. Sujata Viparla. Dr. Sujata?
Yeah, it's literally been an eye-opening lecture. So this is the first time we are hearing about EDCs. And this year in NHM, we got our first shock when there were plaques with plastics and nanoplastics in the plaques, which were associated with a higher risk of myocardial infarction. So as I said, there is an increased cardiovascular disease. I wanted to ask Dr. Gaganpriya, see, all this data is observational. So does this mean causation? Is there something that is going to say that these EDCs are associated with cardiovascular risk?
So I think it's going to be very difficult to prove causation in the traditional scientific sense that we know of, with the medication side effect. There's a direct cause-effect relationship. The epidemiological data is coming from several areas across the globe and giving the same signals, but also mechanistic studies. I did not talk about the animal studies at all, because there is a lot of data in the background from animal studies that is showing a direct causality. Of course, we can't do those studies in human population. And the urinary BPA levels or urinary PFAS levels have strongly correlated with risk after correcting for all other factors. So some of the meta-analysis have corrected for BMI, gender, or the lifestyle factors, all of those factors. The TV viewing was also in one of the meta-analysis. And after correction of all of those factors also, the risk, the odds ratio were, more than 2 or close to 2. So I think we should be on the safer side and assume that, yes, there is plausible causation. In fact, I had put that statement of the Endocrine Society that there is plausible evidence of causation.
Wonderful. We'll take comments and questions from the others. Dr. Emmy Graver.
Yeah, thank you, Dr. Gagan. It was a very wonderful lecture. We all know that endocrine disruptors, they disrupt the endocrine system. And there was always this thought that these may be causing some cardiovascular. So rather than the other risk factors like obesity, diabetes, now EDC may be one of the factor which is coming for cardiovascular disease. Is there any relation that it also increases the biological aging? Because recently, I've heard some lecture that they said that stress and all, it causes genetic changes and it accelerates the biological aging.
Yeah, I think that I did not come across anything direct in that context, but by bringing about climate change, they do affect the heat shock protein. So the rising temperature does act via heat shock proteins to promote biological aging. I'm not sure if the EDC directly is doing it, but is it through the climate change?
Yeah, maybe in next few years that might also come, that it may be accelerating atherosclerosis and also Alzheimer's.
Dementia, there are already links. So dementia work is going on.
Okay. Yeah, thank you.
Very true. There's a lot of association which they've seen with dementia, with autism also. Dr. Swati Ramteke, some comments from you.
So it's always a pleasure, and I always look forwards to whenever and whatever Gagan is going to speak, because as we can see, it's very thorough, the way she presented about it, and it's a very relevant thing in our at least as endocrine practice. We see that every patient, or if not the patient, anybody in his family, that is every family we've come across, we see metabolic diseases, we see obesity, cardiovascular disease, and it makes us think what has changed in these two generations. What was it not like this in our grandparents' generation, what it is there today? It's not just sedentary, or there has to be something else, because our lifestyles have changed, but a lot of chemical intrusion is there into our lifestyles. So this seems very plausible, although causality will take its own time. It's very plausible. What question I want to ask Gagan is not scientific. I want to ask her what changes she had made in her kitchen or in her daily life after going through all this in a very objective way. We all have heard about it in social media, but when we sit and read it as a science, because we have to present or something, what changes have you made, Gagan, in your lifestyle?
Thanks, Swati. So the first thing, day before yesterday, I told Sheila, I'm scared to even touch my mobile and the laptop now. So yeah, but plastic's already gone from our house, like literally replaced for most of the cooking purposes. Even our non-stick cookware is now getting changed to the old traditional pots and pans. Water bottles are changing. So I think these are simple things we can follow up. The cosmetics in the last few years, I think, is all going paraben free. So I think we can take those simple steps and understand what is the chemical substance around us.
Thanks, Gagan.
So small changes do go a very long way. Dr. Asha Mahilmaran. Dr. Asha, you'll have to unmute yourself.
Asha is, I think we'll go to the panel discussion. Asha is not.
I can see her there, but she's muted. So, okay, we'll take comments from her later. Now, thank you, Dr. Gagan, for that wonderful eye-opener talk of yours. And thank you to the expert panel and to the chairpersons for the amazing comments and discussions. We'll move to our session 2, which is round 2's very interesting session. This is the cardio-endo crosstalk. And for this session, I'll invite the moderator to take over. Dr. Snehla Sajid Sheikh will now take over the next session, and she will be inviting the panelists into this session.
Thanks, ma'am. It was wonderful interacting with you for organizing this entire session. It's been an absolute pleasure talking to you, talking to your entire team. And I also love the video initially, and I love the title, Cardiocrinology. So I think together, I mean, women in cardiology and women in endocrinology can actually make great strides. And we all will believe that, you know, women are actually the harbinger of women power. So thanks for, you know, initiating this. Also, special shout out to Beatrice, because she was the one who egged me on, saying that Dr. Sarita Rao is the, I mean, absolute trailblazer, and ma'am, together we can really do a lot of things with, you know, our colleagues from cardiology. So big thanks to all my colleagues from cardiology. A big thank you to, before, you know, we end the session, a big thank you to all the endo friends also, because ma'am at a very short notice, they agreed. So I really wanted to thank them right at the beginning before we start the session. And if I can have the first
intro. Thank you so much to everyone. And you know, CARDIOCRINE today is the initiation, but we are looking to great results, great collaborations, and great work together. I think if anyone can change the world, it's women.
Accepted. I agree completely. And I'm with, and the smile on everybody's faces says it all. So, ma'am, you have everybody on board with you. Thank you. And thank you very much. If I can have the first intro slide, please. We'll quickly get the intros done. So in the interest of time, and then we could possibly go back to the panel discussion, because we really have some very, very interesting discussions out here.
So Dr. Snehla needs actually no introduction. She's consultant endocrinology at Saifi Hospital and Reliance Hospital, Mumbai. She's principal investigator in 35 international clinical trials. Member of the Executive Committee of Endocrinology Society of India. She has published so many papers, review articles, and speaker at so many national, international forums. And from here, Dr. Snehla will take over. Next
Thank you.
slide.
Thanks for those kind words, ma'am. If I can have the next slide, please. It gives me great pleasure to introduce Dr. Beatrice Ann, who is not only a fantastic teacher, associate professor and head department of endocrinology, Nizam's Institute of Medical Sciences, Hyderabad, but a fantastic person, has won a number of awards, authored various articles, and mind you, has authored the chapter titled Endocrine Disruptor Chemicals in Endotext. So that was really very, very interesting when I read her CV. Next slide, please. We also have on board Dr. Ipsita Mishra from Cuttack. We have endocrinologists from all across the country today out here, who's done a DM endocrinology from SCB Medical College and Hospital. Cuttack is the associate professor at this point of time. Number of accolades, has done poster presentation in number of conferences, and is also involved in public awareness programs for diabetes patients and conducting CMEs. A gold medalist, second runner up in ESI TISA 2019. Welcome, Ipsita. Next slide, please. We have Dr. Selaja Anantarapu, who is a senior consultant endocrinologist from Tirupati. Again, has a lot of work under her belt, is at this point of time at Tirumala Hospital, Tirupati, done oral presentations across the different ESICONs, number of journal publications, and has also won the first prize for her paper on bone mineral density. Next slide, please. Ma'am, Dr. Rajeshwari Janakiraman is a senior endocrinologist at Manipal Hospitals, Bangalore, who's also at this point of time at the Amruta Varshini Clinic and Adarsha Nursing Home, Tumkur. I know her from, because we've been investigators in number of trials. So we have been PIs in multicentric clinical trials. She's written various chapters in textbooks for API, Endocrine Society, RSSDI, a complete academician. Very happy to have you on board, madam. Thank you. Next slide, please. It also gives me great pleasure to be making new friends and introducing them. So we have Dr. Shiba Chabra, who's a cardiologist, the first female interventional cardiologist practicing in Punjab. That's really impressive, Dr. Chabra. And who's been awarded a number of awards, a chief editor of the book Clinical Approach and Management Strategies of Medical Ailments in Women Urja, The Power of Her, editor-in-chief of, again, a number of books out there, organizing secretary of WCC 2020, and she's also the director of the WINCARS Association. Pleasure meeting you, Dr. Chabra. Next slide, please. And we also have Dr. Cecily Majella, who has been awarded the International Young Award for Cardiology 2018 at the World Cardiology Congress by the AHA President. Best research papers, first prize for a number of reasons. I can see all firsts over here. Co-authored 30 chapters, authored in 10 international and number of other publications with various presentations under her belt. Thanks for being with us, Dr. Mari Majella. And Dr. Anupam Bambani, who's the additional professor and head department of cardiology at Patna. Again, number of publications, PI at various studies, member of various associations, and her area of interest remain image-guided PCI, fetal echocardiography, and bifurcation PCI. I am sorry if I've mispronounced somebody's name wrong, but it's a pleasure being over here. Next slide, please. I think that more or less sums up the entire introduction. And now if we can go to what promises to be a very, very interesting session. The main aim, I think, Sarita ma'am, and we decided that we should have a meeting where, you have cardios and endos on board together, is for the simple reason that often in clinical practice, the number of areas where, we need each other's help, we need to reach out to each other. There are questions for which I have no answers, and I will bring up my cardio colleagues and try to understand better from them how to manage. And there are also often situations where my cardiologist friends will ring me up and say, okay, look, we are stuck over here and what do we do? And I think collaboration is the way we all need to move ahead. The questions may look a little, disjointed in a sense, since it's just an initial meeting and just more like an introductory meeting to set the flow in pace. We do not have a particular topic where we would be discussing. We just thought of talking about some of the common clinical problems that you and me see and see whether we can find some answers to this. So that was the entire thought process. The reason I'm putting this across to the audience right in the beginning, because you'll wonder, I'm talking about one thing and then I'm promptly jumping to something completely different. So the aim is simple situations, what we are seeing in the clinical world, and try to understand a little in the next half an hour as to what would be the best way forward for us as colleagues. So if I can start with Dr. Shiva Chabra, if I can start with you. Ma'am, we have patients who present to the ICU with atrial fibrillation. They may have severe left ventricular dysfunction, and these patients also have hyperthyroidism. Would your approach in these patients be any different from the cardiology aspect? And I'm also with the same question gonna go to Madam Dr. Rajeshwari, again with the same question as to, would an endocrinologist look at this patient who's come to you in the ICU, you have a call from your cardiologist colleague that this patient is actually having severe hyperthyroidism. What is the thought process? What is the management? What would your approach be? First we could take it from the cardiologist perspective, Dr. Shiva, and then Dr. Rajeshwari.
So thank you so much, Dr. Shleya. It's really great interacting with you, and I can see the energy, that is there in you. And of course, we are going to talk about some very relevant clinical problems, and this is one of the clinical problems which we actually encounter. So, well, we do understand that patients who are hyperthyroid, there is a prevalence of atrial fibrillation of around 68% and incidence of around 14% in these patients. As regards heart failure is concerned, there are around 6% of these patients who actually present with heart failure. However, atrial fibrillation is very significant once we have LV dysfunction. In fact, there have been some articles which report it as high as 90%. So when dealing a patient with hyperthyroidism, of course, rate control in atrial fibrillation is what we actually look and try to target at. We do not really want a rhythm control. We understand that amiodarone, which is 1/3 iodine, which might cause low T3 and acute effects, but later on might precipitate thyroid dysfunction, could be, an issue. So we don't really look for a rhythm control in these patients, and rate control is what we aim at, and beta blockers are the wonder drugs. The non-dihydropyridine calcium channel blockers can be of help. However, we have our concerns when the patients are having LV dysfunction, given their negative inotropic effects. And digoxin against the renal clearance is impaired, and there is an issue of using this drug in hyperthyroid patients, but it can be used occasionally when the patient is in hypotension and left ventricular dysfunction is there, and we have some contraindications for the use of beta blockers. Having said that, there has been a study in elderly patients, it was a population-based study, atrial fibrillation and LV dysfunction. And it was found that the patients who were having the lowest quartile of TSH, they were the ones who had maximum atrial fibrillations. And they are different from the other patients that we actually deal with heart failure is because we understand that this might be a reversible condition. In primary hyperthyroidism, we know that dilated cardiomyopathies, PAH, diastolic dysfunction can be there, and it may revert in 1/3 of the patients. So unlike, thinking that we are dealing with a thing which is going to last forever, we know that it might revert, and anticoagulation is again an issue. We also understand that these patients, especially when they're hyperthyroid, fibrinolysis is altered, hypercoagulable state is there, and we do need to treat them. But then people have believed it to be a reversible situations and just manage these patients on aspirin. So there are so many things which are different, which we need to identify and note about.
Thanks, Dr. Chabra, for pointing out those differences. And if I can go to Dr. Rajeshwari, ma'am, what would your perspective be as an endocrinologist?
Yeah, first of all, I thank WINCAR for having endocrine with them, and it's a very interesting actually the list what we have today, the topics. So as Dr. Shiba said, the problem is it's how we are going to manage differently. It's before that how we recognize if it's a patient who is already hyperthyroid, I am treating them. The chances of them going into, if it's well controlled, unlikely to have a AF or cardiac failure unless they have a different cause for a heart failure. So that is one thing. So people who come with heart failure and AF and hyperthyroid, the first thing is recognition of hyperthyroidism. A lot of time it's mostly elderly. When they have apathetic, they don't have the symptoms of typical symptoms of hyperthyroid, like weight loss of excess appetite. They may not have, they may not be hyperactive, unlike the young people. They are much more slowed down, low appetite. They are apathetic basically. So these are the people who get into AF and have cardiac failure more likely compared to the younger ones. But still, we see even younger patients with hyperthyroid can have atrial fibrillation and less likely with a heart failure. So recognition is the most important. Sometimes you have seen they've been treated for heart failure for a few days with AF, and after that a thyroid test. It may be a week, sometimes 10 days also. And incidentally, they don't find the heart failure is not improving with digoxin or whatever. Then they look at the thyroid. So I think a lot of time may be lost in that. So recognition is the first step, I feel. And definitely, we know cardiologists are good at taking care of the heart rate, so we don't have to worry, and heart failure also. And of course, we have to be very strictly controlling the thyroid, which usually we do carbimazole or methimazole we use. However, some cases, very rarely PTU, propylthyroxine, because it has an added advantage of preventing the conversion of T4 to T3. But most of the time, these medication, carbimazole or methimazole itself, can control the thyroid. But only thing is here, in case they are added, for AF, atrial fibrillation, if sometimes some of them cardiologists prefer amiodarone. So that is when we have some issues. Otherwise, it may not be very difficult to control once the recognition of the or the diagnosis is made. And as Dr. Shiba said, higher chances that the AF can revert to normal. Almost more than 60% can revert to normal, unlike the other causes where only 15% can revert to normal rhythm. So that is very high, that is very good thing if they are hyperthyroid. If it's well controlled, spontaneously they revert. So until such time euthyroid state, they should not try to get a normal rhythm with a whatever the treatments, treatment. And most of the time it's a high output failure, unlike many other causes like cardiomyopathy causing a heart failure. So when high output failure is something that should, I think, make them think it is thyroid could be the cause.
Thanks for them. Ma'am, from both of you all, I kept on hearing about amiodarone. So if I can ask Dr. Cecily Majella that, ma'am, I heard Dr. Shiva also say amiodarone, and Dr. Rajeshwari also said that, no, we don't want to use amiodarone in this situation. Ma'am, according to you, in which conditions you would say, no, I would want to use amiodarone? And other than we all know the effects on thyroid axis, I'm going to go back to Dr. Rajeshwari to ask about effects of amiodarone also on thyroid axis. I would want to know which other side effects of amiodarone would you be worried about when you're, looking after patients which are relevant to an endocrinologist, ma'am?
Yes. When what are the absolute indications of amiodarone is malignant ventricular arrhythmias. So whatever may be the reasons, we need to give them amiodarone, pulseless VT, VF, white complex tachycardias, and a part of the advanced cardiac life support regimen. So whatever may be their thyroid status, these are all 100% usage where we need to use them. But there are certain off-label use where still we use them, especially in atrial fibrillation, as rightly mentioned. When the patient is having LV dysfunction, where we are not able to use the other drugs like calcium channel blockers, when there is a low EF, there are times when we are in a need to use amiodarone. We should also remember apart from the thyroid side effects of amiodarone, whom my next endocrine colleague is going to speak, we should be very aware of the pro-arrhythmic effects or the QTC prolongation of amiodarone, very essential because of the risk of torsades pointus, which could be even fatal for such patients. But also remember, amiodarone or not always causes QTC prolongation. It can also cause torsades pointus without QTC prolongation. There are rare case reports even in such. So torsades has to be monitored, especially in the setting of hypokalemia, especially when the patient is in when there is pulmonary edema or other things, when we are giving them diuretics, the need of electrolyte imbalance has to be carefully monitored in such patients. Apart from the other side effects, we have to, apart from the pro-arrhythmic effects, we should also, all these patients on long-term amiodarone, they develop corneal microdeposits, vortex, this thing. So these microdeposits, 90% are usually benign, and when you stop them, they revert. But there are also rare instances of optic neuritis, very rare, almost less than 10%, where they can go for permanent visual loss, which is very, very important. So these patients has to be monitored, and the eye examination, ophthalmic examinations are mandatory. And also when coming to the liver toxicity, some patients, usually we need to reduce the dose because the primary metabolism is by the liver, whereas in renal patients, we need not reduce the dose. These patients, liver toxicity can occur with amiodarone, and it is usually reversible. Very rarely they progress to, less than 10%, progress to very rarely to cirrhosis. And remember, lung toxicity is one very important part of amiodarone toxicity, where I would like to mention, especially in the post-COVID pandemic, this amiodarone also causes honeycombing appearance and all this ground glass appearance, which needs to be differentiated by other things. Because this amiodarone toxicity, usually it affects the lungs in the apical portions, the right more than the left, and close to the pleural spaces. So bilaterally it will affect, but the right more than the left, abetting the pleural spaces, and CT chest mimicking like ILD, but it is more of the apex than the base, and high attenuation images because of the radioiodine, high iodine content, the deposits being there. That is the reason for the high attenuation lung deposits caused by amiodarone, which usually we have to differentiate from others, because we have to discontinue the drug and settle them and give them a amiodarone-free holiday so that they revert back, because if it becomes permanent, then it will be very difficult to manage such patients. And along with that, other slate-like discoloration of the skin, neurotoxicity, peripheral neuropathy, ataxia, all those things are there. But due to short of time, I think I would complete this. Thank you, ma'am.
Ma'am, thanks. That was an eye-opener, actually, to be very honest, an absolute eye-opener. Because I also see my cardio colleagues using amiodarone quite often. And, generally the patient is sent to us only for monitoring of, we generally, when we see the patient, we only look at the TFT, which Dr. Rajeshwari ma'am will talk about in a few minutes. So now I'm going to look at it much broadly than only at the TFT. Madam Rajeshwari, if you could please also tell us, ma'am spoke about the side effects other than, the thyroid spectrum. But generally, the reason we see the patients are as a result of its effect on the thyroid axis. If you could please tell us a little about that. There's always some confusion about the effects of amiodarone on the thyroid gland.
Yeah, basically what we should know is amiodarone is in very high content of iodine. Almost 37% of the weight of the medication is iodine. So if you take 200 milligrams per day, almost more than 75 milligram will be iodine. So when we compare to the amount of iodine we require per day, micrograms, like 50 microgram, like, so it is so less, and it is in milligrams. So it's a huge rush of iodine into the body. So there are two types of thyrotoxicosis it can cause, or hypothyroidism. Thyrotoxicosis, we all know, there is, as endocrinologists, there are two types. Amiodarone-induced thyrotoxicosis type 1, where actually it is excess of iodine underlying some disease gland was there. In Indian situation, for example, iodine depletes to a great extent. So sudden iodine with a diseased gland, there is usually when extra iodine comes, body after some time has a blocking effect. We call as Wilms takeoff. That is not there in this disease gland. So it continues to produce in excess. So because of the increased iodine intake. So they have thyrotoxicosis. So how it presents, like any other thyrotoxics, weight loss, tiredness, weakness, all these are some of the tremors, anxiety, palpitations, these things. However, if amiodarone is given for some cardiac condition, right? Underlying, she said, LV dysfunction. So initially they improve. I've had some patient who improved very nicely after amiodarone, all the cardiac treatment, and again they suddenly started worsening of the cardiac failure, edema, and such things. Then we looked at thyroid function, and it was thyrotoxicosis was there, type 1. So how do we distinguish from type 2? There is increased blood circulation to the thyroid gland and a Doppler. Iodine intake and all may be very difficult. It is a typical thyrotoxic picture where TSH is suppressed, T4 is high. However, we should know, even without any toxic symptoms, as soon as we start the amiodarone, within a couple of weeks or within a few days, we can see their T4, total T4 or free T4 starts increasing. And how to differentiate from hyperthyroidism? T3 is actually lower in amiodarone induced. It's a drug effect itself. So because that deiodinase is suppressed, so T4 is not converted to T3, it will be converted to reverse T3. That is a normal iodine amiodarone effect. So when they are thyrotoxic, T3 will be high, T4 also will be high. So that is one. The other is this type 2 amiodarone is where there is destruction of the gland directly by the amiodarone. Like how the lung effect, they said liver effect. Similar, directly amiodarone can cause damage to the thyroid gland. It is usually a normal gland without any autoimmune or anything, usually in a iodine deficient areas. So destruction happens. How do we treat? If there is a destruction, we stop the destruction by usually steroid administration. Over a period of 3 months, it can be tapered. Whereas if it is type 1, where is extra production, then we can try and block it with anti-thyroid drugs. Of course, if there some people have a combination, we can give a trial of steroid also with them if they are not improving. But on the long term, if it continues, sometimes they cannot stop the amiodarone. So we have to find a solution like iodine therapy or rarely surgery. I have never gone for surgery for most of the patients. Sometimes, yes, iodine therapy I have done. Yeah.
Thank you. Thanks, ma'am, for making a complicated subject so simple. And I'm going to switch gears now and go to Dr. Anupam Bhambani with another very, very interesting question. Dr. Anupam Bhambani, yeah, I can see. Yep. Dr. Anupam Bhambani, hi. I'm going to ask you a very, very apparently simple question in the sense, we are increasingly, the number of review articles, number of meta-analysis saying that the actual incidence of hyperthyroidism is much higher than what we thought it was. And our index of suspicion also regarding hyperaldosteronism has definitely improved, definitely gone up. It's also one of the lead authors say that you should be doing it practically every patient of hypertension. What is your take on this? What do you think that we should have a very high index of suspicion? Should we be doing an assay in all our patients? Or as a cardiologist, which patient would you say, no, this patient I need to evaluate and this I don't? Over to you.
Yeah, that's actually very important and very interesting question because we frequently overlook this part of the kind of, entire disease, and we overlook it, and that is why we miss it. So in my practice, what I do, if a patient, actually, if patient presents with hypertension, initial evaluation, I always look at the potassium. If there is unexplained hypokalemia, then I always see that there should be some investigation, or at least the common causes of hyperaldosteronism should be looked into, especially if the patient is not controlled with two medications, is requiring multiple medications, and if the patient is relatively younger. But at times, it is not just the younger patients who have secondary hypertension. There can be patients who have been not been investigated into the causes of secondary hypertension, and even when they come to us, they are aged, and we should not always assume that because of the age they are unlikely to have secondary causes and just presume that they have essential hypertension. So if we find that there is unexplained hypokalemia, we should always look for renal artery stenosis primary hyperaldosteronism, look at the physique. If they have a very thin build physique, we should look for Pons syndrome. Then if they have some features of Cushing, then we should investigate into on those lines. And also, if I always take history in terms of rolling out the what is that that cortical part of this. I mean, the increase in epinephrine and all. So I always look into that. If they have unexplained episodes of abdominal pain, sudden flushing, then we just have to look into all the secondary causes. And sometimes, actually, interestingly, I would like to quote a patient who was admitted with diagnosis of some other disease and was admitted for abdominal surgery. But I suddenly received a call that patient's heart rate has gone to more than 200. And I realized the abdominal pain was because of the adrenal tumor. And adrenal tumors, as we know, they are tiny, so they are very often commonly missed unless the radiologist is told to specifically look for them. So, and sometimes we have ectopic adrenal tumors also, which do secrete excessive epinephrine. So then also these patients do have hypokalemia and hyperaldosteronism. And not to forget, there are many patients who, because of the drugs, they have secondary hyperaldosteronism. So then these causes we have to remember. And my practice is that I always look at the serum potassium in the beginning when I come across a new patient of hypertension. And then if a patient who has unexplained hypokalemia, and if they have unexplained difficult to treat hypertension, resistant hypertension, then that is my common practice.
Thank you. Thanks, ma'am, for that. And Shailaja, this patient is now, ma'am is going to send this patient to you. Ma'am has suspected this patient has an adrenal lesion, and this patient has come to you, maybe already investigated partly with the PRA aldosterone assay, or maybe now you have to further investigate. What I want to understand from you is, are there certain caveats, are there certain precautions we should take? Is there something different about doing these assays, or we just tell the lab, okay, please do these assays? And interpretation of these assays, is there something you need to know beforehand or after when you interpret them?
Yeah, thank you, Snehal. And I thank the ESI for making me part of this talk today. So as such, our hormonal assays for the PRA, aldosterone, and cortisols, we need to consider with a pinch of salt. First, for considering for the primary aldosteronism, we need to have some precautions, like the patient should be on the sodium restricted diet, potassium should be in the normal levels. And as we all know that highly sensitive tests usually have high false positive values. And as such, for the primary aldosteronism, we need a test that is the aldosterone-renin ratio, which is the most sensitive screening test, but it lacks the specificity. So there is a high probability of having high false positive values. So once this test is being done, then we have to go for the confirmatory test where we have a quite good number of tests as a confirmatory test, but there is no gold standard. So how to go for this aldosterone-renin ratio is the immunoassays, they measure the plasma renin activity or they measure the direct renin concentrations. So we have quite a good number of commercial kits which measure the direct renin concentration. But if we need to consider the ratio of aldosterone-renin ratio, we take the PRA, that is a plasma renin activity, that is usually taken. And because the plasma renin activity is taken into consideration for this ratio, even if the aldosterone levels are normal and the renin PRA is very low, there is a possibility like false positive high values of ARR, that is the aldosterone-renin ratio, can be seen. So the assay that measures the PRA should be very sensitive, should be able to detect even 0.2 to 0.3 nanogram per ml per hour. So how do we consider the primary aldosteronism is the ARR ratio of more than 30, and the prerequisite is the aldosterone should be more than 15 nanograms per dl. So we need to take both these consideration, not only the single value of any aldosterone or the ratios. We should have both the prerequisites, like the ratio, and along with that, the aldosterone should be more than 15 nanogram per day. So this is the thing for the aldosterone and plasma renin activity, and how we need to consider for diagnosing or screening for the primary aldosterone. Coming to the cortisol assays, it is again quite sensitive test that we have the radioimmunoassays that are available, and there are possibilities like in acutely ill patients or patients having altered protein concentrations, like in malnourished patient or in neonates, there can be the results may not be able to interpret, and we need to interpret considering these conditions. So they are not quite accurate in these situations of altered protein concentrations and in sick patients. So quite now we have the automated liquid chromatography, tandem mass spectrometry, which is quite highly sensitive and highly specific. So especially for measuring these hormonal assays, the cortisol, aldosterone, and PRA, we need to consider the patient we should prepare the patient and go for the testing. And also if the patient is on any antihypertensives, especially for measuring the aldosterone levels, we need to, if the patient is on some drugs like the mineralocorticoid antagonists or on any ACE inhibitors, ARBs, beta blockers, we have to stop those drugs, go for a washout period, especially for the mineralocorticoid receptor antagonists. And then after 3 to 4 weeks, we can consider doing the aldosterone renin ratio. But otherwise, during this period, we can shift the patient to alpha blockers or hydralazine. So these are the precautions that should be taken, and definitely we should see the assay, do the calibrations and standardization, and then we can interpret. Thank you. Yeah.
Thank you, Dr. Shailaja.
Yeah.
I can't.
Yeah, is it audible, Snehla?
You can. Yeah, your connectivity, sometimes I lost you in between a little, but most. Thank you for that.
Yeah.
But thank you very much for talking about, especially the drug. I mean, the fact that, you need to be careful what drugs the patient is on. And I'm going to quickly go through this because I'm Dr. Saeed, or others will not invite me next time saying you're overshooting time. So if I can go to Dr. Sheba and Dr. Beatrice to talk about the new kid on the block. Dr. Sheba and Dr. Beatrice, I'm asking all about finerenone. I mean, I'm perpetually confused about, from the diabetic angle, I want to put the patient with the DKD angle, I want to start finerenone. My cardiologist friend says, no, I'm very happy with spironolactone. How are both of you all going to give me a common consensus? Where is the optimal utilization of finerenone? Dr. Sheba and then Dr. Beatrice. And I'm going to have to sort of trim down. So I'll give maybe
Yeah,
to
of
one
course,
and a
we do
half
understand
minute to
time
both
is
of
very
y'all.
important and we need to end.
Yeah.
So, in brief,
1.5 minute to both
yeah,
of
so
y'all.
finerenone, in brief, it's a non-steroidal mineralocorticoid receptor antagonist. And if I have to briefly mention the trials, so we know about the Fidelity DKD trial and Farrago DKD trial, in which initially primary kidney and secondary cardiovascular, and the Farrago DKD, in which primarily cardiovascular outcomes were studied. And then the Fidelity analysis, came in diabetic patients, especially the ones who were having albuminuria by the the previous trials, were benefited in the terms of cardiovascular outcomes and events. So the other drugs are, eplerenone and esaxerenone, which were studied with finerenone. And finerenone has the beauty of having a great safety profile. So less of hyperkalemia and good antifibrotic and anti-inflammatory effects, which, result in less cardiovascular events. In fact, because the time is less, I would just mention that we've got some fewer upcoming trials, like FINE-1 in diabetic type 1s, FINE-CKD in patients who are not even having diabetes, but CKD, to reduce the progression of CKD and improvised cardiovascular outcomes. And even in patients with renal transplant, it's looking up. So I think it's a very promising drug, an excellent safety profile, hyperkalemia, we don't have to bother. We don't have to bother about gynecomastia. And I would really love to use something which can give good cardiovascular benefit to my patients who are diabetics.
Beatrice, over to you. What's your take on Finerenone?
Thank you, ma'am, for the question. It's always a pleasure to be a part of a panel where you are the moderator. So, ma'am has already talked about the different trials. So what I feel is we cannot really draw a line between cardiac, renal, and renal effects and diabetes. So that's why it's all been pooled now, and it's called CKM. So it is cardiovascular, kidney, and metabolic, syndrome. So looking at it that way, Finerenone, yes, has shown promising results in the Figaro DKD and the Fidelio DKD trials. And we also have the heart-specific trials as well, the FINE-ART-HF, which also showed some promising results with reduction in heart failure events. So in fact, that's why Finerenone is now incorporated in the guidelines as well. So the ADA 2024, as well as the ESC 2023 update. So both of them. So the ADA 2024 says that Finerenone should be considered for CV risk reduction in patients with type 2 diabetes, CKD, and albuminuria. And when it comes to the cardiac part, the 2023 ESC update has incorporated it in the guidelines saying that Finerenone needs to be considered for prevention of heart failure in patients with diabetic CKD. So yes, very promising results with Finerenone. And Finerenone, if you compare it to eplerenone or spironolactone, has stronger anti-inflammatory and anti-fibrotic effects. And as endocrinologists, we do not have to worry too much about the off-target effects, sexual side effects of Finerenone, because it's very specific for the mineralocorticoid receptors and no effect on the HbA1c as well.
Thanks. Thanks, Beatrice. That was really crisp. If I can again go to Dr. Cecilia and ask her, ma'am, since we're talking about the adrenal gland, ma'am, when you look at a patient, I mean, you have a diagnosed patient of, suppose you have a diagnosed patient of pheochromocytoma, for example. How would you actually manage if the patient comes to you in a hypertensive crisis? Are there different drugs? What would you actually do? And Ipsita, I'm going to come to you, asking you that suppose you have a normotensive pheochromocytoma, the hypertensive crisis, I'm going to ask Dr. Cecilia. I'm going to ask you, you have a normotensive pheo, which we do see in clinical practice. Would you still prepare the patient for surgery? Or would you just say, okay, you can just take up the patient? First, Dr. Cecilia, and then Dr. Ipsita. I can, believe me, give you all only 2 minutes. I can't cross that now. I am now got the timer on my head.
Ma'am, patient known pheochromocytoma presenting with a hypertensive crisis, definitely the first drug of choice would be IV phentolamine, 1 milligram up to 5 milligram IV, followed by every 1 milligram per minute infusion till the BP and the alpha adrenergic blockade is completely knocked off. Then only a beta blocker can be given. Along with that, if necessary, a calcium IV nicardipine can be given, or an IV NTG if the BP is still not under control. But the diagnostic dilemma always lies when a patient already known pheochromocytoma, but we should also look into the target organ damage, the multi-system involvement, especially the heart, the kidneys, and also the thromboembolic complications. So when the BP gets controlled, everything is under control. A low dose of heparin, after assessing the tumor size, if it is more than 4 centimeters, the risk of rupture is there. So at that times, we need not give them any heparin or anything. But when a patient presents with pheochromocytoma crisis, the thromboembolic complications should also be kept in mind. And we should also look into that and treat it if necessary, because if there is an impending rupture of the tumor, then we should stop hold of the heparin because it will be life-threatening and may cause mortality. Thank you. For the short time, I think I can show.
Thank you, Shala ma'am, for having me part of this. So contradictory to the thought that pheochromocytoma will always have persistence of hypertension, it is now found that the normotensive variants do exist. The exact mechanism of why they are normotensive is just proposed. Probably if they would have been having a bleed into the tumor, or if there is a baroreceptor desensitization, or if they have pre-existing vasodilation along with them, these will have a kind of normotensive presentation. Now, the next point comes is whether to treat them with alpha blockade pre-operatively What was found in some studies was that the risk of hemodynamic instability during the perioperative period is almost equivalent to the hypertensive fears. There are few group of urologists and the surgeries which have been done in the best of centers. They have tried them without alpha blockade, and some studies says that the results were fairly good enough. But what they found on the retrospective part was they did not have any pre-existing cardiac lesion. They did not have any kind of dysarrhythmias prior to surgeries. But in the other group, they found that those who had pre-existing cardiac forms, especially the Takotsubo cardiomyopathy and pre-existing ventricular tachyarrhythmias, if you do not give a blockade, then there is always a crisis of a HDI. Because anytime the heart rate can shoot up, and you cannot give a beta blocker without advocating an alpha blockade priorly. So it's a very contradictory theory. There are two school of thoughts, and what I feel is that it has to be patient tailored. There is no large RCT which can tell or not tell, but definitely if you calculate that if the tumor size radiologically is on a large size beyond 4 centimeters, even if they are normotensive, you never know that at the point of surgery, they can land up in crisis. And if they have pre-existing cardiac lesions, especially the myopathy and the arrhythmias, then you must advocate them alpha blockade, even if they are normotensive prior to surgery. So that is what is my take, ma'am.
I totally agree with you, Chika, because sorry, Dr. Cecily, please.
Yes, ma'am. Just one word. This fibrocytoma crisis, type A and type B. One is hypertension. The other one is with profound hypotension also. Apart from hypertension, severe hypotension lasting for more than 20 minutes, which will require IABP, ECMO, and all those supports. And always the precipitating causes. Normally, when they present with pulmonary edema, all those things, the precipitate direct intubation even can precipitate a crisis. So, a surgery, bleed, or even routinely, we do not intubate such patients directly, rather than give them some anesthetic agents, and then because just a frank intubation may even further worsen the crisis.
Honestly, ma'am, I feel scared because the previous center where I was working, the urologists, they are taking up a study where they are trying to go for a surgery without a blockade. But then my heart does not agree for that. I mean, I get scared.
I would be petrified. Okay. It's Dr. Shailaja, if I can go to you with a very, very interesting, I think as I said, the most hot topic nowadays is MAFLD. We seem to have changed the nomenclature also. We feel that MAFLD is the harbinger, or I would say the surrogate marker of cardiovascular disease. What do you think is the link between the two? And we see fatty liver all the time. All our sonologists very happily label everything on earth, I think, as grade 1 fatty liver. And my patient is more worried about a grade 1 fatty liver than that hyperglycemia. So what is your take on the link between these two?
Yeah, previously we used to hear about the NAFLD, non-alcoholic fatty liver. Now we have the metabolic dysfunction associated fatty liver. That is nothing but a fatty liver disease associated with either overweight or obesity or diabetes. So how is that related to the cardiometabolic? Does that carry any cardiometabolic risk? So as of we know that non-alcoholic fatty liver disease or even MAFLD is associated with increased risk of cardiovascular disease. So how is that? The studies has shown that these patients have high rates of ASCVD. 10-year risk of ASCVD is high. And these patients with MAFLD have arterial stiffness, endothelial dysfunction. Thus, the brachial artery vasodilatory responses are reduced. They can have carotid intima media thickness, and coronary artery calcification scores might be high. And they are at risk of, these are all associated with the MAFLD. So as such, thus gradually there can be increased deposition of the triglycerides in the liver with the reduced clearance of the LDL, finally resulting in fibrosis, metabolic dysfunction, and sometimes even involving other organs like the kidneys, causing the CKD. So as such, these patients are prone to have increased cardiovascular risk because of the carotid intima media thickness and also increased risk of ASCVD. And there are also evidences of echographic evidence of cardiac diastolic dysfunction in these patients. So these patients should be considered for all these, and they have to be advised regarding the lifestyle changes and the pharmacological treatments. We have quite good number of drugs available, like even the SGLT2 inhibitors are also now in vogue with all these drugs available, and we have to be advising the patient regarding the preventive therapy for the MFLD. Thank you.
Thanks, Shailaja. If I can, in the interest of time, if I could quickly go to Beatrice and ask her about a very, very interesting topic. Beatrice, we talk about MHT more often now. Is there anything like a critical window hypothesis? And what is its connection really with cardiovascular health? Is it going to really help me as far as cardiovascular health? It's always received a very bad name. I mean, people are still hesitant about MHT. What is your take on it, Beatrice?
Yes, ma'am, there was a lot of hue and cry after the results of the Women's Health Initiative, because that had shown an increase in the CV events, an increase in the risk of stroke, increase in the risk of pulmonary embolism, and increased CHT after the patients were started on MHT. But then there were observational studies and a few other trials which had shown the opposite results. That, when you start MHT, it actually reduces the CV events and it improves the all-cause mortality. So why was this difference? And this was because of something called as a timing hypothesis. So it depends on when you start the MHT. So closer to menopause, less than 10 years, and if the patient is less than 60 years of age, that would be the right time to start MHT rather than much older. And as you see, the Women's Health Initiative, the mean age of those women were about 63 years. And the sort of patient population that we start on MHT are much closer to menopause, so about 45 to 50 years. So those are the patients that we tend to start on MHT. And the timing hypothesis is important because this is based on something called as the healthy endothelium hypothesis. So estrogen, when it is given to somebody whose endothelium is relatively healthy, let's say who's about 45 to 50 years, so there it has a protective effect compared to somebody who already has subclinical atherosclerosis or an established plaque. So somebody who's above 55 or 60 years of age. So estrogen, they are more prone to the thrombotic and the inflammatory effect of estrogen. And so that is why patients, when you start a little later on MHT, they tend to have more CV events. So yes, we should utilize MHT more, but the timing is very important.
Excellent. I think that's very, very important. And if I can go to Ipsita, post AMI or post in a patient with cardiac failure, what would your crisp advice be as far as contraception is concerned? And then most probably I'm going to be taking the last question to Anupam and one question to Shailaja. And unfortunately, in the interest of time, I will have to call it a day. I mean, I have tons of other questions to ask, but unfortunately, I think the organizers want me to say, okay, that's it. So Ipsita, just a very crisp, short answer, contraception in a young patient post AMI or failure.
Use of contraception, the light was thrown into after the results of the WHI trial. Already Beatrice ma'am has quoted it. And considering AMI, US Medical Association regarding the use of contraception, they revised their guidelines in 2016. And they put that if you're using contraceptive under two headings, like containing a estradiol preparation, containing a progesterone preparation. So, ma'am, estradiol preparations are definitely, they come under the unacceptable risk category for a lady who has got AMI. But if you look into the progesteronic preparations alone, progesterone alone preparations, so under that, we technically have four categories: a POP, implant, or DMPA, and another one is the levonorgestrel IUD, I guess. So now, if you look into all these four, other than DMPA, the rest three, their use is mentioned under the category that the benefits outweigh the risk during the initiation point. So the progesteronic preparations, apart from DMPA, they can be used, but the risk of failure in terms of fertility is higher with the progesteronic devices. Definitely. That's all.
Thank you. Thanks, Ipsita. Dr. Anupam Bhamani, I'm going to come to you with one question. We are increasingly talking about NT-proBNP in clinical practice. We as endocrinologists have started using it much more. There was a talk recently where there was about you using it maybe in annual health checkups. What's your advice to us as to where do we use it? And then maybe Shailaja can say a few words on SGLT2 inhibitors, and then I'll have to call it a day.
Yeah,
Please,
okay.
yeah, Dr.
So
Anupam.
in the most concise words, I would like to say that we should practically use NT-proBNP in two situations. One, we use it as a negative predictive marker. So whenever we have cases, because it is raised in so many conditions, cardiac and non-cardiac, that its positive predictive value is really, really low unless we rule out all the situations which, other than cardiac, which can cause a rise in NT-proBNP. It can be sepsis, it can be renal failure, of course, or volume overload of any etiology. So that is one thing, that its negative predictive value is more helpful in clinical practice than the positive predictive value. So if it is negative, it is definitely not heart failure. Now, number two, in cases where we are monitoring the treatment of heart failure, so we for serial measurements, that tells us that the therapy which we are using is effective or not. Otherwise, if we start using it for annual health checks, it can be raised even in simple things like hypertension because of the diastolic dysfunction. So NT-proBNP, because we all know it is, as the name also suggests, it is secreted from atria. So in anything that causes rise in the filling pressures of the ventricles or rise in the atrial pressures, it would be raised. So we should try avoiding its use as the diagnostic marker for its positive predictive value.
Thank you. Thanks for that, ma'am. Shailaja, absolute last 2 minutes, absolute indications for SGLT2 inhibitors, and Dr. Rajeshwari, ma'am, absolute contraindications for SGLT2 inhibitors, and then I will hand it over back to Dr. Sarita Rao to for the vote of thanks.
Yeah. As we know, for the MAFLD, there are quite good number of drugs. We have metformin, vitamin E, statins, pentoxifylines. We have polyunsaturated fatty acids, PPAR gammas. Then we have GLP-1 receptor agonists. Now we have the SGLT2 inhibitors, which are coming out to be the promising candidates for the management of MFLD. So how are they? What is their role is? Other than the anti-hyperglycemic effects, these drugs have the antioxidant and anti-inflammatory effects. So how do they reduce the MFLD? Is they reduce the endoplasmic reticulum stress, oxidative stress, they reduce the low-grade inflammation, autophagy and all. So in that way, it reduces the inflammation, thus becoming a promising molecule, and there are quite good number of studies being done on the canagliflozin, DAPA, empagliflozin, and even on the toflogliflozin. So there are very long-term studies are required, and their upcoming trials are even there regarding these drugs, and they are expected to be promising molecules in the management of MFLD. Thank you.
Thank you. Thanks for that. Rajeshwari, ma'am, absolute contraindications for SGLT2 inhibitors, 1 minute, and then we hand it over. Ma'am, you're muted.
Sorry. Yeah. If there has been a severe form of like a pyelonephritis or any UTI that is very severe, definitely I will never use in that patient. And if they have had a, would not, and if they have a cerebrovascular disease, again, I wouldn't take the risk. Yeah. Unless there is a compelling reason the cardiologists want to use it, still I would be very, very careful.
Thank you. Thank you, ma'am. Dr. Rao, I've tried my best to, stick to time. I know I've still overshot a little, but it's just that my excitement gets the better of me. It's been fantastic talking to everybody over here. And I would like to hand over the session back to you. Thank you, everybody. Over to you, ma'am.
Dr. Snella, this was an amazing endocardio crosstalk. And it's been so interesting looking at the endocrinology perspective of what we cardiologists think. So it's been so fascinating that actually we could be here for a much longer time and go on about it. But all good things, they must come to an end. And I want to thank Dr. Snella and her entire team of endocrinologists for this wonderful CARDIOCRINE collaborative event. All the speakers, all the panelists, and the chairpersons, they've done a fabulous job, and we are looking forward to further collaborations. WINCARS is actually about women in cardiology and allied sciences. So as such, we welcome all of you onto our WINCARS platform. We will be sending you invitations, and we look forward to more such meetings and more such conferences. We also have an annual conference called WCC. We'll make sure that we invite all of you to it this time. And it's been a great evening with great learnings and great sessions. Thank you to everybody who was part of it. And also thank you to all the attendees for staying put.
Thank you. Thank you very much.
Thank you,
Thank you,
Snehla
everybody.
ma'am. And
Thank you.
thank you.
Thank you,
Good
ma'am.
night.
Thank you. Thank you, ma'am. Thank you.
Thank you. Good night.
Thank you.
Good
Good
night.
night.
Thank you, everyone.
Thank you, ma'am.
Bye.
Thank you, everyone.
Amen. Bye.
Bye, everybody.
Bye, ma'am.